Welcome, dear friends. Today we are honored to bring together a diverse group of countries and stakeholders, including representatives from ministries of health, implementing partners, policymakers, researchers, public health professionals, to discuss what they are doing to integrate neglected tropical diseases into broader national health systems. As you know, GON has been organizing a series of webinars since the closure of USAID to share what domestic opportunities the countries have identified to overcome the challenges. And it has been very rich. We have learned a lot. And today is one more of this series of webinars. And as we all know, we all are at a pivotal moment in global health with a lot of changes, a lot of challenges, evolving priorities, and growing complexity. And yet, within this shifting landscape lies a powerful opportunity, the chance to embed NTD programs into the health systems much more deeply. Countries are being super creative. They are doing a lot of things. They are owning and standing up to own the programs and to not let the damages cause problems into the communities. And today we are going to share wonderful things that countries are doing to overcome many of these problems and many of the challenges in very creative manners, demonstrating what has been happening already for many, many years, this change towards a much more owned NTD community, a much more owned NTD programs where the governments, the health systems are being centered and where they are really owning these programs to make sure that they are not dependent into the external funding and that they are much more sustainable. When we talk about these global health transitions, we are referring to a change in funding models with an increasing demand for resilient, people-centered health systems. These transitions are challenging us, but are compelling us also to innovate, what is really good. NTD integrations into health systems is not just a technical adjustment, it's an strategic imperative nowadays. By aligning these NTD interventions within the existing platforms like primary health care, child health base, nutrition and immunization campaigns, we can optimize the resources, we can reduce duplication, and we can ensure that NTD services are delivered consistently and sustainably. This is nothing new. We have been talking about this for decades. You know it better than me. And we are seeing successful examples. Countries have successfully integrated NTD's drug distribution into school health school health programs, and through vaccination programs. Others have trained frontline health workers to deliver NTD treatments alongside routine services. These efforts are not only cost-effective, they are building trust, strengthening systems, being more sustainable, and bringing us closer to universal health coverage. But let's also be honest. Integration is not without its challenges. We know that health workers sometimes feel overburdened, that our systems sometimes are not prepared and do not capture NTD indicators. In many cases, NTDs are still seen as vertical programs. They feel disconnected from the broader health priorities. So to overcome these barriers, we need to invest in capacity building, advocate for NTD medicines to be included in national essential drug list. We have to mobilize domestic resources to reduce resilience to be just dependent on external funding. It also means that we need to ensure that the supervision and the monitoring are integrated so we can maintain the quality and the accountability. And this is what we are going to be talking about today. To address these issues, WHO is committed to support countries through the technical guidance, capacity building, advocacy, and we are working with partners to strengthen health information systems, to promote domestic financing, and to ensure that NTDs are part of national health priorities. So as I told you a moment ago, today we are inviting a variety of actors to share with us what is happening in the field, because everyone has an important role to play, from ministries of health, who all of them must have a strong vision and policy alignment, implementing partners that must bring technical expertise and innovation, donors that must be flexible and allow these integrative, creative approaches and provide more long-term support, The communities that are always at the center have to provide also the opportunity to engage, to be engaged from the planning phase, be informed at all times, and be empowered to make decisions and adjustments. Looking ahead, we must seize opportunities that come with change. We need to remember that digital tools can help us to track progress and improve service delivery. We must make sure that we don't forget cross-sectoral collaboration to amplify our impact. And of course, GONE is a global learning platform that can help us to share what works and what is inspired, what can be inspiring, to what we can innovate from other countries. We can learn from others and bring this innovation in our countries. So today, I am truly delighted to share with you what innovative approaches are being implemented at country level to promote integration into the health systems and across different global health programs. These are real-world examples that have been implemented in countries that have worked, and we are going to hear them from the countries themselves and from the implementing partners. I encourage you all to participate actively, engage through the chat, take notes, share your own experiences, and we will open the chat, we will open the discussion at the very end to ask questions, to have a lively discussion. So make sure that you take notes of what you would like to share and to start already having a conversation through the chat. Thank you so much for your commitment. I am really impressed when I see more than hundreds of people connected to this webinar. And I'm going to ask my colleague Nadia to now put the agenda on the slide so I can introduce it to you. And we can discuss. So we are going to start first with an important presentation from Rwanda and Togo, where they are going to talk about strengthening integrated approaches to entities. So we have Ladias from Rwanda, we have Fiham from Togo. Then we are going to follow up with a presentation from Ethiopia, Kenya, and Uganda, where we will talk about integrating entity interventions into the primary healthcare services. That will follow from a presentation from Madagascar and Tanzania on how to embed entity integrations within nutrition and vaccination campaigns, and real examples of what they have done in their countries. We will then continue with Benin and Niger, talking about incorporating entity programs into current existing platforms. Then we will have quite a long time, 25 minutes for discussion. And we will then end our webinar with a wrap up where Carol from the MFAN, we will make a summary of what we have listened and extract some conclusions for us and next steps. So without any further delay, I'm going to give the floor to our first speaker. So please, Nadia, if you can actually play the recording from, I think the first one is Ladislas. Thank you so much, Nadia.
Thank you for this good opportunity to share with you the status of entity integration in Rwanda. I'm Ladislas Chimimana. I'm the acting director of NTD and other parasitic diseases unit within Rwanda Biomedical Center, which is the implementation entity of the Ministry of Health. A brief about Rwanda. Rwanda is a country located in the East Africa, and we have around 13 million population, having female with a higher proportion. And Rwanda, across all the country, we have around 60 community health workers supporting the community health system. So we have done a lot in integration of NTD, mainly starting with the Mass Drug Administration. So the Mass Drug Administration in Rwanda has been integrated, and we implement MDA for STH and Schisto at the same time. But not only that, because we have integrated MDA in maternal and child health week, where we are implementing different services and engaging different partners. For instance, malnutrition screening, vaccination, as well as distributing mass drug administration. So we plan and implement and we coordinate together, engaging different partners and different ministries. So the implementation of MDA, it's implemented by different partners, including the community, where the community health workers play a big role. In a school, it's implemented by teachers, coordinated by the head of schools, and at the health facility if it is needed for patient visiting the health facilities. So beyond this integration within the maternal child and health week, we are now piloting the integration of MDA into routine services within the community health system. So we have worked with partners and developed the system. So we are training community health workers using a smartphone where they will be implementing different interventions, including mass drug administration, where they will be using individual data in the drug administration. Now we are piloting in one district, and the document guiding this implementation is under process for endorsement. Then we will scale up after the pilot in one district that has been selected. So we have also integrated vector management, including snail, mosquitoes, and flies, where we have trained entomologists in a different domain, including malaria control, mosquitoes, snail control for schistosomiasis, flies, where we train them in breeding site mapping for onchocerciasis, which is ongoing in the country. Now we have already identified the breeding site, now moving for the serological survey for this. So we are now starting the integration of skin and TB screening. We have already started within 4 districts, where we have already trained 74 healthcare providers, including nurses and medical doctors, and trained around 400 community health workers who screened people or patients with a skin condition, and we have identified some entities using this simplified screening tool. So as you can see, we have integrated also NTD data in the HMIS, where NTD elements are being reported within the one national HMIS. So this is also the surveillance, where the disease targeted for surveillance are also recorded within HMIS, not as a separate entity system, but for the whole country. So we have learned a lot from this integration, because it allows the joint planning, implementation, and the partners coordination, as well as efficient use of resources, because a few humans and staff, they are supporting different activities as well as financial, and it has supported a lot in improving data collection and quality check, because we are doing it jointly. Also, it's a good opportunity when you have a budget constraint. Then if you integrate, you use less resources than doing a single intervention. It allows also accountability and sustainability of the intervention, because at a certain point, when we have challenges like the current funding freeze, so we make sure that the intervention can continue within integrated manner. This is what I can share with you, and from what I have learned in integration in the country. Thank you.
That was really impressive from Rwanda. Now we are going to hear from Togo. With us, we are project, and I please encourage you to make comments to Rwanda in the chat, please. He will respond in real time. He's here among us, between us, and he will be responding to your chat directly. So make sure to project comments to him.
Bonjour tout le monde, je suis Dr. Nyosike Piham, coordonnateur du programme Maladies tropicales négligées au Togo et je vous présente aujourd'hui l'expérience de l'intégration des maladies tropicales négligées au Togo. Slide.
Feel free to use the interpretation channel to listen in English.
Donc, c'est une réalité, l'intégration des maladies tropicales négligées au Togo, et on le voit à deux niveaux. Au premier niveau, il s'agit d'une intégration au sein même d'une même coordination de toutes les maladies tropicales. Et comme dans tous les autres pays, avant 2018, il y avait une approche de prise en charge des maladies qui était centrée sur chaque maladie. Et aujourd'hui, à partir de 2018, après la recommandation de l'OMS, nous avons eu la fusion de tous les programmes verticaux multiples en un seul programme et à travers un arrêté ministériel avec un coordonnateur national qui est nommé par arrêté ministériel. Nous avons également un TDM qui est intégré depuis 2010 et qui intègre à la fois l'onchocercose, les schistosomiases et les helminthiases. Nous avons réussi à intégrer également au niveau des évaluations onchocercose avec des évaluations post-validation, surveillance post-validation du trachome. Et nous sommes en prévision d'une autre intégration avec, entre une évaluation d'impact schistosomiase et l'évaluation une surveillance post-validation de la filarose lymphatique. Nous avons également des enquêtes intégrées entre les TDM et la prise en charge des morbidités ou encore des outils de formation et de sensibilisation qui sont intégrés. Nous avons ces outils qui comportent à la fois toutes les maladies tropicales négligées qui sont prioritaires au Togo. Nous avons réussi également à mettre en œuvre de façon intégrée toutes les activités sur les maladies tropicales négligées à manifestation cutanée. Slide. L'intégration également est une réalité au niveau intra- et extrasectoriel. C'est ainsi que sur le plan extrasectoriel, il a été mis en place, le Togo a mis en place un cadre national de coordination multisectorielle des maladies tropicales négligées qui est sous la présidence du secrétaire général du ministère en charge de la Santé. Ce cadre qui a été créé en 2022, fonctionnel depuis 2023, comporte 3 commissions qui recouvrent tous les aspects de lutte contre les maladies tropicales négligées au Togo et 3 comités d'experts. Ces commissions et ces comités d'experts font des réunions régulières au moins 2 fois par an, environ 2 fois par an. Nous avons les représentants également de 12 ministères de plusieurs directions de division au sein de ce cadre, y compris WASH et également le ONE-F. Nous avons également réussi à avoir avec le ministère de l'Éducation un cadre de travail qui est matérialisé par une convention et qui a permis de mettre en œuvre un traitement de masse schistosomiase, helminthiase en projet pilote dans la région maritime. Diapo. Alors, quels sont les enseignements et les défis qui sont liés à cette intégration? Donc, le premier enseignement que je partage avec vous, c'est la mise en œuvre que l'intégration a permis de mettre en œuvre des projets sur certaines maladies tropicales négligées qui n'ont pas d'appui spécifique, telles que les envenimations par morsure de serpent. Mais cela, en même temps, soulève le défi de flexibilité de certains partenaires qui sont encore parfois résistants à faire financer certaines MTN qui ne sont pas dans leur portefeuille. Le deuxième enseignement, c'est l'intégration au sein d'un seul programme qui a permis de faciliter la mise en œuvre d'approches intégrées. Mais cela relève également le défi d'un organigramme fonctionnel parce que cette intégration complète de toutes les maladies tropicales négligées parfois peut être assez difficile à gérer sur le plan fonctionnel. Il y a également la mutualisation des ressources qui est une réalité, qui est un gain de cette intégration et qui pose également le défi de l'allocation des ressources adéquates, puisque quand vous mutualisez les ressources, parfois les partenaires et l'État ont tendance à donner moins parce qu'ils pensent que vous êtes déjà intégré. Il y a un autre enseignement très important, c'est que il y a eu une croissance de la rentabilité de l'appropriation du programme. C'est devenu plus rentable, c'est vrai, parce que le TDM est intégré, par exemple, mais nous pensons qu'il est très important que nous puissions augmenter les efforts pour mobiliser les ressources domestiques. Je vous remercie.
Hello everyone, this is Tasfan from Ministry of Health Ethiopia. I will present the country experience on integration. So I'll present on the NTDs campaign that are integrated through the primary health care and also through other health campaigns, or I will see also the advantage of integration and what challenge we have and the way forward. Ethiopia is one of highly populated country in the African continent, and so we have around 13 entities that are prioritized and included in the national entities program. And entity is already embedded and mainstreamed through the primary healthcare unit, especially in the district health office, in the health centers, health posts, and the community, since entity is implemented mainly at the community level, and all the community mobilization, drug distribution, health awareness activities are conducted and integrated through other horizontal health activities. Ethiopia has been selected to be one of countries that can just integrate the health campaign into one campaign schedule, or just improving and raising the effectiveness of the program since 2023. And there was establishment of a steering committee, and the campaign schedule has been planned together with the stakeholders, donors, and program officers. These are some of the programs that are selected to have the integration, and you can see entities among the 5 of selected, and especially mass drug administration, entity case screening are selected to be integrated through other health campaigns. And you can see those campaigns can be just delivered at a fixed site, house to house, school, or community based. So these are the delivery sites, and entities are selected or grouped under the school based, especially deworming program is under the school based delivery, because Ethiopia is deworming 5 to 15 years children, and at the community level, LF, ONCO are grouped at the community with non-communicable disease screening, malaria, and trachoma is grouped with non-communicable disease screening, malaria, and nutrition. The integration opportunities are training. We can integrate the training because the health extension workers have one integrated refresher training. There are manuals that incorporate entities. The social behavioral change communication is also incorporates the entities, and also data collection. Obviously, Ethiopia has one reporting tool, that is DHIS, HMIS2. We have only one logistic system, and entity medicines are under this system, starting from the quantification up to leftover drug management, supervision, and planning also incorporates NTD in the current health system. The advantage is obviously we can mention it's very economic since the distance is very short. No need of just paying for per diem for health workers. The data management uses the existing platform, no separate logistics system. Just a screening of common illness can be done when we just conduct the mass drug administration, including the TT screening during the campaign. The challenge, of course, we should just refresh all the health workers, health extension workers just repeatedly. There will be some interruption of routine service during the mass drug administration, and there will be a delay of drug delivery, and we couldn't just conduct the mass drug administration at attended or intended time. The way forward, still we can make the NTD training digitalized. The Minister of Health starts just a artificial intelligence assisted guidelines training is, and to just provide in person and also even in virtual. And also we shall recommend just to have short mass drug administration campaign days, not to interrupt the routine health service at the health post or the health center. And we can use this opportunity to strengthen the NTD case screening, and also we can improve the NTD medicine delivery time by submitting the requests earlier. And thank you, WHO country office and headquarters for preparing me for this presentation. Thank you.
Thank you so much, Nadia. I'll be sharing with you the Kenyan experience in embedding NTD services into primary healthcare for sustainability. My name is Wycliffe Omondi, head NTD program. Kenya launched its third master plan for elimination of NTD 2023-2027 with the key focus on integration, looking at 4 preventive chemotherapy NTDs, bilharzia, intestinal worms, elephantiasis, and trachoma. We identified 2 pilot counties, Kilifi and Siaya. However, there's also ongoing implementation in some of the counties outside these 2, with the implementation looking at 5 key thematic areas, which I will go one by one out of these 5. The first one is on the service delivery, and looking at a shift from the routine MDA campaigns. We want to make treatment routine through primary health care using the community health promoters. We are also incorporating NTD case identification at the facility level through diagnosis and also treatment within this facility. But of course, as highlighted by some of our panelists before, we are also leveraging on existing health campaigns such as school health, maternal and child health. We've also integrated our vector surveillance for NTD vectors during the malaria vector surveillance. I will give example where we've integrated successfully MDA for LF together with that of intestinal worms, where we use either mostly albendazole and therefore avoiding treating the same community members with the same molecule at the same time, then following later with that for schisto using praziquantel. Through this integrated MDA, cost savings are realized during advocacy, social mobilization, and community sensitization that is covered as one package as compared to when you want to run the MDAs at different times. This also goes a long way with the pool logistics. On the second, the integration as an health information system, and we've done this through incorporating the indicators into KHIS, as well as utilizing the community health information system and onboarding into KHIS. We use this information to provide feedback at different levels for planning and decision making. On the third key elements of integration is human for resource, and we had a cascade kind of empowering the healthcare workers with the NTD information, both from the national to the subnational. But the key is the service providers, who are the community health promoters, whom we provide this information. On the right, you can see the NTD module within the Ministry of Health Academy as one of the key tenets of sustainability of empowering healthcare workers with NTD information. Key to sustainability is ensuring that the messages get to the grassroots of the community members impacted by these NTDs through a robust health promotion system to identify preventive measures the community can use to avoid getting infection through behavior change. And this has been is being run by health promotion team through integration process. Now, we've also done domestic resource mobilization by first ensuring that we are able to include entities within the budgets at the national level as well as the subnational level. If you look at the right hand side of the projection, is one of the subnationals that have budgeted for NTD, and here is a purchase of albendazole worth 3.8 million Kenya shillings, which is equivalent to roughly 30,000 USD to treat the impacted community members. Again, we are also pooling resources for health products, but lastly, to cushion the impacted patients from catastrophic out-of-pocket, we've included the NTDs within the social health insurance by costing them such that people who are subscribing to this insurance are able to get treatment. A number of challenges exist, such as lengthy government bureaucratic processes. We also experience a shortage of NTD health products. For example, when a county requires 2 million tablets of praziquantel, it is not locally available. So getting it from the international becomes difficult. We also, another example is a shortage of test kits. For example, for leishmaniasis, we ran out of kits. It is not also available globally. So in as much as you want to integrate and provide these services, there is a scarcity or lack of health products for NTDs. I'll also just cycle on some of the concluding recommendations, such as leveraging on the existing primary health care that have enabled us to see reduced, avoiding duplication, reducing the cost and improving sustainability through the existing system. Because of time, I will exit, and thank you for the opportunity. Over to you, Nadia.
Thank you. Morning, everyone. My presentation was recorded, but I don't know whether I should go ahead and present.
No, it's all right. We will just play it, but be there because there's going to be questions for you.
Okay.
Thank you so much. We cannot hear anything from this presentation.
Even I don't hear me, even me I don't hear, but I can read it.
No, hold on 1 second. We are gonna try one more time, and if not, we give you the floor to present. But
Okay,
we give just one more try because it was
okay.
working before.
African trypanosomiasis, scabies, rabies, and snake bites.
No, you have
All
to
cases
restart it.
management entities are integrated into primary disease.
Voila. Thank you.
Stand Commission of vector-borne and ectotropical diseases, Ministry of Health, Uganda. The integration of NTD into primary care services. Uganda is endemic with all 5 preventive chemotherapy, ectotropical diseases, and individuals case management NTDs like cancer, human African trypanosomiasis, scabies, rabies, and snake bites. All cases management entities are integrated into primary care services in Uganda like cancer, sleeping sickness, rabies, TT surgery, hydrocele surgery, and scabies. Uganda does not have health care insurance scheme, but she adopted universal long-lasting insecticide nets campaign and indoor residue spraying, which have helped in control mosquitoes and sandflies that transmit rhinitis and cancer respectively. How does MDA for explain how MDA for 5PCT are integrated into other health campaigns? Uganda has got 5 preventive chemotherapy NTDs, that is rhinitis, trachoma, mucormycosis, schistosomiasis, and soil-transmitted herniasis. The first 3 PCT, that is preventive chemotherapy, are no longer in public health program in Uganda. For example, mass drug administration for hepatitis in all 60 former endemic districts stopped. Only 4 out of 37 formerly Osakasi endemic districts are still doing MDA, and only 2 out of 51 formerly trachoma endemic districts are still doing MDA. The MDA has been, as the mass drug administration, has been integrated into child health days, which was successfully launched last year, and Uganda was able to save 10 million tablets since child health days target the same age group population of under 5 years, but also pregnant mothers, women. The steps for this successful integration. There is a political will at the Ministry of Health for this integration. Since senior top management endorsed it. The permanent secretary wrote a circular on behalf of the senior top management in all district health officers and hospital directors in charge to integrate all health services into mainstream. The letter helped the division of vector-borne ectotropic diseases to work with the counterparts in Uganda National Expanded Program on Immunization in this integration. Therefore, the division of vector-borne NTD and UNEP conducted a joint micro-planning, capacity building for nurses, and biostatistician for data sharing. And the district has NTD focal person who would take care of our drugs, that's transplanted, to ensure it reaches the intended beneficiaries. And also the reverse logistics was also done jointly. Advantage of integration, there was reduced duplication of campaigns since it was taking place at the same time, yet targeting the same population. There's increased the country ownership since MDA is always seen as an activity for implementing partners with less input from the ministry. There is reduced cost on MDA since the division of vector-borne almost put zero budget in the budget, yet the exercise was done. The capacity building for its workers to manage MDA and other NTD interventions. There is integration of logistics, including drugs, into the list of essential medicine, so the government will soon start acquiring these drugs for stocking in mainstream. Disadvantage there's overloading too much work to health workers. Therefore, procedures like giving transplanted dose according to the height were not followed. There was bias among the health workers who give priority to usual child health package, leaving behind transplanted not administered. The HMIS tools for child health had no variables for MDA, therefore difficult to rely on the data. The Praspantile mass drug administration was for school age child and school age child, which was being conducted in schools, not in the community. Next. Tackling these challenges, there is a need for capacity building for health workers and administering NTD drugs. There is a need for integration of NTD medicine to national research list for medicine, so that they are procured by government. Mobilizing the next financing for NTD programs, and there's a need to integrate technical support supervision from central NTD endemic areas. Next. Recommendation: we recommend that the donated drugs should have long shelf lives so that they are stocked in the health facilities. There's a need for capacity building for health workers in mass drug administration campaign, and some operational funds are needed to conduct supervision during the child health days. Since there is no fund to support the division staff. Thank you very much.
Thank you so much to the three panelists for sharing all these important insights and also for sharing with us all these challenges that you are facing as you try to implement. Now we are going to move to our next panel, where we will be hearing from Madagascar and Tanzania. Madagascar has had an excellent experience integrating the lymphatic filariasis programs into the polio campaigns, and Tanzania will be sharing with us the integration into the nutrition programs. So please, we are going to upload again the presentations.
À toutes et à
Remember
tous,
to continue posting
c'est
the
un honneur
questions.
pour moi aujourd'hui de représenter notre pays, de vous partager l'expérience de Madagascar par rapport à l'intégration via l'administration massive de médicaments contre la filariose lymphatique et la vaccination contre la poliomyélite. Pour ce faire, nous allons suivre le plan classique en vous donnant la méthodologie, les résultats et nos facteurs de succès. Tout d'abord, Madagascar est une grande île avec une superficie plus de 587 000 km², hébergeant une population plus de 30 millions et répartie dans 23 régions et 114 districts. Parlons maintenant du contexte de la filariose lymphatique à Madagascar. Parmi les 114, 87 parmi eux sont encore endémiques à la filariose lymphatique, dont 4 sont déjà en arrêt de traitement. Comme nous voyons sur la carte colorée en orange, ce sont les districts endémiques, et en bleu, ce sont les districts en phase de surveillance, et en vert pour les districts non endémiques. Cette maladie expose encore plus de 69% de la population malgache, et ça fait déjà plus de 15 ans qu'on a lutté contre cette maladie. Nous avons eu un progrès. Nous avons eu un grand progrès, c'est-à-dire on a passé de 82,4 à 76,3% de 2018 à 2023 des districts endémiques. On a aussi une endémicité avec d'autres maladies tropicales négligées, telles que la schistosomiase qu'on y trouve dans 89 districts, joelminthiase dans 89 districts et la ténia dans 54 districts. Pourquoi avons-nous choisi cette approche? Eh bien, c'est parce que dans notre pays, il y a déjà un engagement fort du gouvernement à améliorer l'accès aux soins de santé primaire par des modèles intégrés de prestations tels que les cliniques mobiles, les caravanes médicales. Également, il y a le soutien des partenaires au développement. Il y a aussi l'utilisation d'outils et de prestataires comme entre les deux programmes qui réduit les coûts et limite les doublons. Et la communication conjointe, le plaidoyer, l'engagement communautaire, renforçant ainsi l'appropriation et l'impact à tous les niveaux. Quant à l'étendue géographique de cette activité intégrée, nous faisons le traitement de masse une fois par an, ciblant les populations plus de 2 ans, et nous avons adopté les 2 stratégies, bithérapie DA et trithérapie IDA. Nos activités ont concerné de 2116 centres de santé de base et 15 055 villages. Nous avons pu mobiliser 30 110 distributeurs communautaires Et notre administration de masse dure environ de 4 à 5 jours habituellement, mais peut être suivie d'un ratissage si nécessaire. Alors, pour la méthodologie maintenant. Pour l'estimation des économies financières liées à cette intégration, nous sommes concentrés sur 7 volets: la coordination supervision, la logistique, le déplacement et indemnités, la communication et les formations à tous les niveaux. Et pour chaque catégorie, on a pris la différence entre les dépenses potentielles sans intégration et avec intégration. L'économie totale de ces deux activités est égale à la somme des économies réalisées dans les 7 catégories de coûts. Ce qui nous donne comme résultat, en 2 ans, nous avons pu économiser plus de 1 230 000 $. Vous voyez, comme par exemple sur le graphe là, en 2023, au lieu d'utiliser 1 398 897 $, nous avons mobilisé que seulement de 340 727 $, ce qui est équivalent à 24% de nos besoins. Grâce à cette approche intégrée, le programme a pu économiser entre 75 à 86% des ressources qui auraient été nécessaires, et cela démontre la grande rentabilité d'une planification, d'une logistique et d'une mise en œuvre conjointe. Et ça, cette slide, c'est pour toujours vous montrer les résultats, c'est-à-dire le progrès grâce à l'intégration. Madagascar a pu avoir pour la première fois de toute l'histoire un taux de couverture géographique à 100% avec l'atteinte des objectifs escomptés, que ce soit dans le cadre de l'AMM contre la filariose ou que ce soit dans le cadre de la vaccination contre la poliomyélite. Quels sont nos facteurs de succès? Ce sont surtout liés à la forte leadership de Monsieur le ministre de la Santé publique, et même malgré les entraves. Mais il y a aussi, grâce à l'appui du représentant de l'organisation de l'OMSPI, qui est le lead de tous les partenaires techniques et financiers. En plus de cela, il y a l'opérationnalisation de la coordination en mettant en place un quartier général avec les équipes du programme élargi de la vaccination et les équipes de maladies tropicales négligées. Il y a la planification conjointe, la formation des agents de santé, la logistique par la mutualisation et par exemple, au lieu d'envoyer un camion à moitié vide, on a pu mettre les intrants de médicaments avec les vaccins et les différents outils de gestion. La supervision, au lieu d'envoyer en avion les superviseurs, on a économisé d'intégrer la supervision ensemble. Et on a mis en place aussi un groupe WhatsApp pour lier à la fluidité de communication. Pour résumer à tout ça, donc, on peut dire que l'intégration de l'administration massive des médicaments contre la filariose lymphatique et la campagne de vaccination contre la poliomyélite, nous avons montré une efficience et l'atteinte des objectifs fixés entre les deux programmes. Et cette intégration est un catalyseur du progrès national. La réussite d'intégration des activités nous a permis d'accélérer considérablement le progrès vers l'élimination de la filariose lymphatique, car, par exemple, l'année dernière, nous avons pu mener une enquête d'impact de traitement auprès de 32 districts. Et comme ils ont tous passé cette année, ils sont éligibles aux enquêtes passant de fin de traitement. Et en plus de cela, 27 districts sont aussi éligibles de mener une enquête préliminaire, l'enquête de MS, Epidemiological Monitoring Survey, cette année 2025 aussi. Et nous sommes confiants que nous allons arrêter le traitement de masse en 2026 et nous allons passer à la phase de surveillance pour pouvoir contribuer à l'élimination de la filariose lymphatique d'ici 2030. Sur ce, je vous remercie sur votre aimable attention.
Hello everyone, I'm Clara Jones, the NTD Manager at the Ministry of Health Tanzania. I'll share with you strategic embedding of NTD interventions within nutrition campaign, drawing on our direct experience from the districts of Longido, Monduli and Ngorongoro. Our ultimate goal was to sustain the progress in the fight against NTDs. Tanzania faces a significant burden of NTDs where we have the 5PC, namely LF, OV, Schisto, SCH, and trachoma. We also manage various case-managed diseases. To combat this, our program employ key strategies. These include MDAs, mobility management and disability prevention, which specifically address conditions like trichiasis, lymphedema, and hydrocele. We also do advocacy and sensitization on behavioral change to foster community engagement, strengthen our health system, and robust monitoring and evaluation, which include surveillance surveys and operational researches. The map on this slide illustrates the co-endemicity of various NTDs across Tanzania, highlighting the areas where STH, Schisto, LF, OV, and trachoma are prevalent. So why integrate? The core rationale lies in achieving powerful synergies and efficiency as an immediate solution following the funding crisis. As we all know, integration offers significant and cost effectiveness by reducing operational cost as we deliver multiple interventions simultaneously. This combined approach was meant to increase coverage, allowing us to reach more individuals by leveraging existing community networks and combining our efforts. We've observed compliance from community members who are more likely to participate in a comprehensive health initiative that addresses multiple needs. So this strategy also reduced the overall burden on the health system by streamlining delivery and minimizing the need for separate campaign. And also, we all know that nutrition in NTD campaign often target vulnerable population. Therefore, this integration provided a critical entry point for both interventions, and this allowed us to address the interconnectedness of malnutrition and NTD susceptibility, and by doing so, we ended up strengthening our health system because we involved health workers and CHW who are already involved in nutrition as well as NTD program. Let's turn to our specific experience in the districts of Longido, Monduli, and Ngorongoro. These areas presented unique opportunities for integration due to the co-endemicity of soil-transmitted helminths and trachoma alongside the existing nutrition campaign need. And so the map on this slide visualizes the prevalence of STH and trachoma in these specific districts, showing the varying percentages. And these districts were scheduled for nutrition campaign, which was meant to start from 1st to 30th of June. Our interventional strategy here involved integrating 3 key components. Trachoma MDA, which involved mass drug administration for azithromycin to all individuals aged 6 and above, targeting an estimated population of more than 600,000. STH MDA, which we implemented MDA of a single dose albendazole, and the goal was to deworm children aged 1 and 15 years, targeting an estimated population of more than 300,000. These 2 MDAs were integrated with our nutrition campaign, which included vitamin A supplementation and mid-upper arm circumference screening, or the MUAC. Our distribution strategy combined both house-to-house and fixed-point approaches to ensure maximum reach and maintain the conventional method which are employed in both nutrition and community MDAs. The success of this integration was built on a well-coordinated mechanism across multiple levels. We used our existing implementation structure to coordinate the integration. At the central level, the National NTD Program, together with Nutrition Section and the PO-Large, collaborated on preparations and planning. Moving on the regional level, strategic review and planning meeting were held with the Regional Health Management Team, the RHMT, and Council Health Management Team, the CHMT, alongside high-level advocates and resource mobilization. At the council level, focus was on logistic support to CHW, training of frontline health workers and teachers, and managing medicine distribution. And finally, at the ground, which is the community level, our frontline health workers from the health facilities and CHW were crucial. Their activities included social mobilization, detailed planning, training of CHW, drug distribution, and essential data collection and reporting. This multi-level coordination ensured that the integrated service were delivered effectively and efficiently on the ground. The images on this slide shows health workers engaging with community members and conducting training sessions, illustrating the hands-on nature of this integrated approach. We achieved significant success through this integrated model, but most notably was that MDA for trachoma and STH was successfully implemented, demonstrating its feasibility and effectiveness using domestic own sources. Now we are waiting for the reports on coverage. The image on this slide shows community health workers distributing medicine and interacting with children and adults in the field, representing the direct impact of these efforts. However, we also encountered some critical challenges. The training required for staff on multiple intervention was complex, demanding more time and comprehensive training materials. Managing the diverse supply chain for different drugs and supplements also presented a logistical hurdle. We experienced longer client interaction time due to the multiple services being provided, which could potentially impact the output. Furthermore, data collection and reporting for these multiple integrated services proved to be a challenge, requiring careful coordination. Lastly, we noted challenges with CHW turnover due to inadequate incentive and transport facility, and also there are some delays in payment which could affect continuity of services. To address these challenges and capitalize on our success, we've identified several best practices for future integration. First and foremost is robust coordination, which is very essential. Secondly, comprehensive training is vital. Thirdly, streamlined logistics are of paramount. Fourthly, integrated data management is necessary. And finally, a community-centric approach is fundamental. In conclusion, our experience in Tanzania demonstrates that embedding NTD-MDAs within other intervention campaigns, such as nutrition campaign, is highly effective and synergetic approach that significantly enhance reach and efficiency. This powerful model contributes significantly to sustaining progress toward our elimination target for NTDs, and this requires sustained investment, including continued political commitment, adequate funding, and technical support, which are all crucial for scaling up and sustaining such integrated efforts. Tanzania experience in Longido, Monduli, and Ngorongoro paves a path toward more integrated and impactful public health intervention, driving us closer to a healthier future. Thank you very much for your attention and listening. This marks the end of my presentation.
Will be in French again.
I invite.
Merci. Bonjour à tous. Je suis Dr. Ndeye Marie Bassabi Aradji. Je vais vous présenter l'intégration. Diapo. Pour le TDM Conco, nous avons utilisé la plateforme communautaire et chaque relais est responsable de 200 ménages. Et les ivermectines ont été administrées au cours de ce TDM-là par ces relais qui ont en charge 200 ménages.
Pour le TDM Schisto-Géo, pour les enfants inscrits à l'école, nous avons utilisé la plateforme scolaire. Donc, chaque enseignant est responsable de l'administration des médicaments au niveau de sa classe. Et pour les non-inscrits, ce sont les relais qui ont fait le travail dans la communauté. Diapo. Les différentes étapes que nous avons utilisées pour l'oncocercose, il y a eu des initiatives de plaidoyer, une prise de main par la partie nationale. Nous avons replanifié les activités. Nous avons optimisé les ressources parce que, comme vous le savez, c'est FHI qui s'occupait du TDM Onco, mais avec son départ, il a fallu faire des plaidoyers avec d'autres partenaires, en l'occurrence AICV, mais nous avons dû optimiser les ressources pour tenir dans l'enveloppe que AICV avait. Et nous avons mis en œuvre le TDM à les relais communautaires du gouvernement et ces relais n'ont pas été payés. Aujourd'hui, au niveau du Bénin, il y a une politique de santé communautaire où les relais sont pris en charge par le gouvernement et chaque relais en charge 200 ménages. Chaque jour, nous faisons des réunions journalières pour voir l'évolution des résultats et ajuster ce qu'il fallait ajuster. Et le lendemain, on mettait en œuvre les recommandations. Diapo. Par rapport aux schistosomiases et géohelminthiases, le ministre de la Santé a discuté avec son collègue de l'enseignement primaire. Ils ont pris des notes de service pour pouvoir informer les enseignants et leur dire comment le TDM va se passer, puisqu'il n'y avait aucune ressource. Donc, tout a été fait sur les ressources nationales. Nous avons acheminé les médicaments et les intrants en direction des départements et les ICP, c'est-à-dire les infirmiers chefs postes, se sont chargés de les envoyer au niveau des directeurs d'école qui ont remis les médicaments à chaque enseignant. Il y a eu la formation des enseignants et des relais communautaires où c'était 100 sous, ils n'ont pas été payés, puisque avec les différentes négociations, ils ont compris la situation. Donc, c'était sans coût. Après, il y a eu une supervision conjointe du ministère de la Santé et du ministère des Enseignements maternels et primaires pour voir comment l'activité se tenait et régler les problèmes qui se posaient au fur et à mesure. Puis, nous avons eu la transmission des résultats par les acteurs du ministère de l'enseignement maternel et primaire à travers des fichiers remplis. Diapo. Les avantages observés autour de cette intégration, il y a optimisation des ressources. Par exemple, pour le TDM Onco, nous avons réduit de 3 cas et pour le TDM Schisto, comme je l'ai dit, c'est de 3 cas et pour le TDM Onco de moitié plutôt. Il y a eu un renforcement des capacités locales. Comme il faut s'approprier maintenant ces deux stratégies, on a renforcé les capacités locales. Il y a une mobilisation communautaire où on a demandé aux acteurs communautaires de nous aider à mobiliser les communautés pour qu'elles adhèrent. Il y a eu maintenant une absence de péremption des médicaments puisque ces médicaments devaient être périmés si nous ne faisons rien. Et il y a eu une amélioration des résultats des TDM, surtout celui de l'oncocercose, vu qu'aujourd'hui, avec la plateforme communautaire, les relais sont payés mensuellement par le gouvernement et les partenaires. Et avec ces deux expériences, il y a une résilience qui a été démontrée. Quels sont les défis? C'est de renforcer la coordination nationale et internationale pour que nous puissions voir comment affiner ces différentes stratégies et renforcer de façon continue les capacités locales pour une gestion indépendante en optimisant les coûts. Les recommandations pour une intégration réussie, il faut des initiatives de plaidoyer en direction des parties prenantes et une réduction des coûts, renforcer les capacités locales, comme je l'ai dit, à tous les niveaux, et faire des supervisions conjointes pour pouvoir réussir les activités. Merci.
Thank you so much. And now our last panelist in Niger, Dr. Salisu, please. Just bear with us one more second.
Donc, c'est un honneur pour moi de partager avec vous l'expérience du Niger en matière de traitement intégré des maladies tropicales négligées. Le Niger est un pays de plus de 1,267 million km² avec plus de 26 millions de personnes. Les maladies à chimiothérapie préventive touchées par le traitement de masse sont la schistosomiase, la bilharziose, la fibrose lymphatique, le trachome, le germanchiase et l'onchocercose. Ces maladies sont endémiques sur pratiquement l'ensemble du territoire national avec des spécificités. Et nous avons commencé à mettre le traitement de masse depuis 2007. Et cela a toujours été fait de manière intégrée. Pourquoi il fallait intégrer? On devrait intégrer parce qu'il est nécessaire pour nous de mettre en œuvre, en commun, les jamais ressources que nous avons, les ressources financières, de mettre en commun les ressources humaines que nous avons, qui ne sont pas assez nombreux, de mettre en place le petit matériel nécessaire et cela nous permet aussi d'économiser du temps. On devrait mettre en commun toutes ces ressources pour pouvoir avoir un optimum de moyens pour mettre en place notre stratégie, afin de mettre en place donc le TDM par une même équipe au même moment avec la même logistique. Tout cela rassemblé nous permet de mieux gérer les ressources financières déjà maigres, de mieux gérer le temps matériel des agents de santé qui ont plusieurs sollicitations afin d'avoir une performance en termes de taux de couverture de nos traitements et aussi d'impact. Quelles sont les étapes du TDM au Niger? Au Niger, on commence par la microplanification. Et cette microplanification qui est faite avec les districts est faite de manière intégrée pour l'ensemble des 5 maladies à chimiothérapie préventive. Après planification, nous faisons la commande des médicaments, les médicaments qui se font avec les mêmes supports qui sont proposés par l'OMS. Nous faisons la formation des acteurs de terrain, aussi bien les agents de santé jusqu'au niveau communautaire, avec un module intégré qui tient en compte de l'ensemble des 5 pathologies. Nous faisons une mobilisation de social intégrée et un lancement national qui est toujours fait par son Excellence, Monsieur le Ministre de la Santé, est fait au nom de l'ensemble des 5 pathologies. Après, donc, le lancement national commence la distribution de masse. Cette distribution de masse est faite pour chaque village par un seul relais. Un seul relais distribue le mectisant associé à l'albendazole. Il distribue le praziquantel. Il distribue aussi le Zydromax. Ils le font de manière séquentielle une fois pendant cette campagne qui se fait uniquement. Après la campagne, pendant la campagne se fait la supervision. La supervision se fait en cascade. Une équipe nationale quitte pour aller superviser au niveau de les régions et des districts l'ensemble des molécules qui sont distribuées. Parce que c'est une campagne unique. Les régions vont aussi superviser. Le chef CSI, le chef de centre de santé de proximité supervise la campagne qui concerne l'ensemble des maladies et qui se fait en même temps. À la fin de la campagne, nous faisons une évaluation au niveau de chaque district et l'évaluation concerne l'ensemble des molécules distribuées. Nous faisons une évaluation au niveau de la région, puis une évaluation nationale qui est unique et pour l'ensemble des 5 pathologies. Pendant l'intégration, ce n'est pas aussi facile. L'intégration a des difficultés. L'une des difficultés la plus importante, c'est le retard, en cas de retard de la mise en œuvre, les difficultés qui entraînent le retard de la mise en œuvre sont surtout ceux liés à l'insuffisance de la logistique. Certaines insuffisances liées à la logistique en cas de retard, par exemple, des médicaments. Il peut y avoir souvent l'ensemble des médicaments pour 2 ou 3 pathologies qui sont là, mais le 3e ou le 4e ou bien le 5e peut être en retard. Nous avons certains consommables, certains métiers matériels relatifs à 1 ou 2 pathologies qui peuvent être en retard. Cela met en retard le lancement de l'activité. Nous avons aussi comme difficulté la surcharge de travail des agents de santé. Parce que vous les demandez de faire tout ce travail ensemble, alors qu'ils ont aussi d'autres sollicitudes. Là, les mêmes de même aussi pour les distributeurs communautaires. En dehors de la recherche de travail, nous avons certaines spécificités de certains programmes qui sont noyés. Pour ce qui concerne la filage lymphatique, on a tendance à souvent, pendant nos campagnes, à mieux apprécier certains paramètres, comme par exemple ceux relatifs à la mobilité, la recherche des cas, mais du fait de la grande sollicitude, donc des agents que nous impliquons sur le terrain, cela est un peu noyé. Nous avons aussi l'illégale répartition de certaines maladies, comme l'onchocercose et la schisto, qui sont souvent liées à certains foyers. Cela entrave la stratégie nationale qui est demandée, que nous mettons en œuvre de manière uniforme à l'échelle d'un district. Parce que pour l'onco et la filariose lymphatique et la schisto, souvent, c'est des villages qui sont surtout concernés. Et là, vous voyez, ça crée un peu un dysfonctionnement. Ça met en œuvre un peu, ça met en retard un peu l'uniformité de l'intervention que nous mettons en place. Mais les difficultés ne cachent pas les avantages. Beaucoup d'avantages pour ce qui concerne l'intégration. L'un des avantages le plus important, c'est la réduction du coût. Nous avons estimé à plus de 2/3 la réduction du coût que si cela se faisait de manière verticale. L'intégration facilite la coordination et la supervision. Dans un contexte de rareté de ressources, nous n'avons pas suffisamment de personnel. Une équipe qui sort, elle supervise l'ensemble des molécules qui sont distribuées. Nous avons l'amélioration de l'offre de services et une meilleure couverture, parce que le fait qu'on a les moyens, le maximum de moyens pour aller mettre ensemble le TDM pour l'ensemble de 5 pathologies ensemble, le fait qu'on se concentre et que toute une période est réservé pour la mise en œuvre de cette activité nous permet d'avoir le maximum de résultats. Nous avons aussi des facilités de l'adhésion de certains partenaires pour la mobilisation des financements. Cela nous permet, l'intégration nous permet une utilisation optimum des ressources financières et humaines. Elle permet aussi et favorise l'harmonisation des interventions des partenaires. Elle permet surtout un gain de temps pour les prestataires et l'amélioration globale des indicateurs de santé au niveau de notre pays, à cause de la grande sollicitude des agents de santé. Merci beaucoup pour votre aimable attention.
Thank you, Dr. Saliso, for this last presentation that was super helpful, and it ended in a very high note, highlighting all the benefits of integration. I think we had great presentations today, more than 260 people connected, and over 80 questions have been raised. We still have 24 not answered yet. Therefore, I encourage you, in the interest of time, unfortunately, we are not going to have time for a live discussion, but I encourage you to follow up offline. As you know, GON is importantly a communications platform. So we can now follow up with each of the presenters, email them, WhatsApp them, have a conversation, and make sure that we learn from what they have done to make sure that we can learn from this experience and implement in our own countries to improve our programs. And I'm going to give the floor for the last remarks and the closing remarks to Dr. Carol from the MFAN. She is the co-chair for GON with Dr. Makata from Nigeria. And she will be wrapping up and having some summary remarks and closing this webinar for us. Dr. Carol, the floor is yours.
Yeah, thank you. Thank you so much, Maria. Let me see if I can get my camera working. I hope it is. And thank you, everybody, for joining today. As we wrap up, it's clear that integration brings significant advantages. The first advantage that I see and that has been discussed here today is the benefits that come to the individual who receives multiple services at one go. That way, that means that they can go around their day as they should without having to stay home 10 days, 5 days waiting for an MDA. Well, it can all be done at one go. The next level of benefits is really programmatic. And this comes from the reduction of duplication, as many of the countries have shared. It strengthens country ownership. It builds the capacity of the health workforce. They become a lot more imaginative. And in many instances, it saves cost. However, as we've again had today, there's challenges. And one that was mentioned across the countries is the increased workloads and some of the system's limitations to offer multiple services at the same time. Tackling this requires continued investment in training in domestic financing, and also in stronger supervision. With thoughtful planning and collaboration, we can ensure that integration is not only streamlines our effort, but also enhances the impact of our NTD programs within the health system. Again, thank you for joining us today. This was such an important webinar that begins to talk about how we strengthen health systems through neglected tropical diseases integration. So we are just not ending neglected tropical diseases, but we are also, by so doing, by integration, we are strengthening the health system. Most importantly, what we had today was country experiences. Many of the program managers on this call, those that spoke and those that did not, are figuring out how do we do this better? How do we integrate better? It is our job as partners to continue to support them as they figure these out for themselves and for their countries. So I want to thank our panelists. As you might say, they were really outstanding. Their thoughts and contributions were highly insightful, and they're drawn from real-world experiences. They may not be perfect, but they're innovative. They show how the thinking that went into this, but they also provide us valuable perspectives on how NTD integration can be a powerful lever for stronger, more resilient health systems. We truly appreciate the time, effort, and expertise that you brought to these discussions. To our audience, your engagement, thoughtful questions, and reflections made today's session even more dynamic and meaningful. The richness that we've had today from the discussions just continues to reflect your commitment to advancing this work. As we move forward, let's continue to collaborate, learn from one another, and champion integrated, equitable, and sustainable approaches to the health system strengthening. Thank you again, and we look forward to continuing with these vital conversations with all of you. Over to you, Maria.
Well, I think you said it all, Carol. So we are, with your wonderful words, we are going to close the webinar here and again encourage you to continue the conversations. This was so rich. This has to be only the beginning. Please reach out to all the panelists. Let's make sure that we improve our programs and we make the best to make sure that we don't we don't punish the people in the field by these funding cuts and all these problems that we are experiencing. So we will see you very soon in our next webinar, and have a wonderful rest of your summer all. Bye.
Thank you, everybody. Thank you for joining.
Yeah, thank you. Bye.
Goodbye.
Bye.
Au revoir tout le
Et bonne
monde.
soirée. Au revoir, Clara.